Good evening, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, our stalwarts need no introduction, but it's our great pleasure and honor to introduce her. She is none other than Professor Dr. Madhurata Alexander, ma'am. Ma'am is MD in Obstetrics and Gynecology and Professor at Osmania Medical College, Hyderabad. With ma'am's wonderful insights, we are going to talk about the topic for today, which is growth restriction, IUGR. So now, without any further delay, I would like to introduce the topic in brief. So, in this intricate mechanisms underlying IUGR, including placental insufficiency, maternal factors, fetal conditions, and environmental influences, we will be discussing about the clinical manifestations of IUGR, highlighting the importance of early detection through prenatal screening and diagnostic tools such as ultrasound and fetal monitoring. IUGR presents a significant challenge in maternal fetal medicine, impacting the health and development of the fetus. This webinar seeks to provide a comprehensive understanding of IUGR, exploring its causes, diagnosis, implications, and management strategies. So now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Oh, thank you, Batul, for this kind introduction. And this is a nice topic that we have chosen, growth restriction and IUGR. Um, Now, what is IUGR? Intrauterine growth retardation. It can either be a small baby or a big baby. Mainly, we'll be focusing on the small babies. It's a common complication of pregnancies. It involves nearly 5 to 10% of all pregnancies. Now, what is it? It's a pathological condition where there is a restriction of growth in utero and the fetus does not attain its full growth potential. It is the third leading cause of perinatal mortality after anomalies and prematurity. 40% of all stillbirths are IUGR. So therefore, it's very important to us. And we, as obstetricians, we are having this problem very frequently, day in, day out. In fact, now I work in the public sector and we find a lot of patients, a lot of doctors referring patients to us to monitor them because the facilities in our government hospitals have really improved. And we are able to also tackle these babies with good neonatal backup and good outcome. What are the problems of IUGR? To make the diagnosis is difficult because there is a lack of consensus. Basically, terminology. What is IUGR? There is a problem in the terminology. Everyone is not agreeing on the same thing. The etiology is lot of etiology is there, and the diagnostic criteria for fetal growth restriction. Now, also the other problem is compounded by the fact that it's difficult in differentiating between the fetus that is small for gestational age versus IUGR, because some babies, because of genetic reasons, are basically small, whereas some babies fail to grow. That's what we call IUGR. And also the main thing is there is uncertainty surrounding the optimal management and the timing of delivery for the growth restricted fetus. Now, if you look at all small babies, about 70% of them are constitutionally small. They are not pathological, they are physiologically small. So those should not be worrying us. Another 20 of them are small because of uteroplacental insufficiency because of various causes, and they usually have asymmetrical IUGR, which I'll be coming to shortly. Now, only about 10% of them are because of chromosomal, structural, or early infection, and these babies are having symmetrical IUGR. What are the various types of IUGR? The symmetric IUGR, that is the weight, the length, and the head circumference are all below the 10th percentile. What generally most countries have fixed is anything below the 10th percentile for that gestational age. If it is the weight is below, it's called IUGR. Asymmetric IUGR is the weight below the 10th percentile and the head circumference and the length are preserved. That is, the weight is less, but the head circumference and the length of the baby are preserved. This is called the head sparing, and in these cases, abdomen is small. This is not so serious as a symmetrical IUGR. If you look at the normal rate of fetal growth, at about 20, the time of TIFA scan, the baby's weight is about 300 to 500 grams. At about 28 weeks, the baby weighs about 1 kg. And slowly, in the latter part of pregnancy, the weight becomes exponentially more. At 15 weeks, the baby's weight gains about only 5 grams per day, but at 35 weeks, it's about 35 grams per day. There is also a variation by the race, gender, and multiple gestation. If you look at the various phases of growth, in the first, there are 3 phases. The first one is the first 16 weeks, the second is 16 to 32, and the last and third one is more than 32 weeks. In the first phase, the growth is mainly cellular or hyperplasia. The cells are increasing in number. From 16 to 32 weeks, there is both hyperplasia and hypertrophy. More than 32 weeks, it's mostly hypertrophy. Thus, early growth restriction will affect cell numbers and have a global or symmetrical effect. That is, as I said, the baby's head, the length, and the weight all will be small. It will be symmetrically small. Later, only the other parts of the baby are small, but the head is preserved, is called sparing. If you look at the growth inhibition in stage 1, the baby will be small with fewer cells. The cells will be numberally small, but maybe the cell size is normal. This results in symmetrical IUGR. It's about in the first stage. 1/3 of cases are having symmetrical IUGR. The associated conditions are genetic, congenital, etc., infectious infections, smoking, substance abuse, and irradiation. Now, in the second and third stage, what I told you after 16 weeks, the decrease in cell size and fetal weight, but there's less effect on the total cell numeric, fetal head, fetal length, and head circumference. This results in asymmetric IUGR, and mainly this is what we see more commonly, that is, because of uteroplacental insufficiency. What happens when there's fetal hypoxia? As we know, like in the adults, the aortic body has chemoreceptors. They get stimulated. And there's a reflex redistribution of fetal cardiac output. The vital organs are preserved. What happens to the fetal cardiac output? They're redistributed, where the organs like the kidneys, the lungs, the gut, the liver, the muscle body fat, and the glycogen stores. There's a decreased flow to all this. That's why when there's the kidneys, they have oliguria. The gut, the liver, all these have decreased flow. But there is increased flow to the vital organs, that is the brain, the heart, and the adrenals. There tries not to be a compromise for the blood flow in these organs. What are the various causes? They can be maternal, fetal, or placental. I'll just run through the maternal causes. They're only listed here. The main ones are chronic disorders that are associated with any vascular disease. The main one, what we are all very familiar with, is the pregnancy-related hypertensive disease, that is preeclampsia plus or minus chronic hypertension. Here we know there's impaired trophoblastic invasion and there's atherosis and necrosis, leading to reduction in the uteroplacental blood flow. The antiphospholipid syndrome is an acquired one. It's not seen in hereditary thrombophilias. Remember that. In the hereditary one, it's not seen, but in the acquired one only. The gestational diabetes, that is pre-gestational. The one that what the gestational diabetes, what happens in those people is, usually you see a macrosomia because of the other causes. Renal insufficiency, cyanotic heart disease, all these also contribute to maternal causes of IUGR. Fetal causes, multiple gestation, yes. Always multiple gestations, the babies are smaller size than a singleton gestation. Congenital heart disease of the baby, gastroschisis, genetic and structural disorders in trisomy 13 and 18. What about the placenta? Any small placenta, usually the fetal-placental ratio is more than 10, and any chronic abruption of the placenta or post-term. The growth restricted placenta looks like this on the right side. What is the developmental incision of the cord? That is, the umbilical vessels, as you can see here, they traverse the fetal membranes and then they reach the placenta. The main thing is here, what happens is, when you rupture the membranes, if these vessels are torn, then the baby can get exsanguinated. These babies also are smaller than normal. The battledore placenta is on the right side. The cord is attached to the margin of the placenta. This also contributes to a smaller baby. There was 2 growth restriction trials, but only one published randomized trial, to assess the timing of delivery. This is always a puzzle to us. When do we deliver? Now, if you have take a baby less than 34 weeks, they have randomized babies. That is, you either deliver them within 48 hours of diagnosing IUGR, or follow an expectant management group. When they did that, they gave in both these groups they have given betamethasone, and they have realized that the perinatal survival was similar. And when you followed these babies at about 6 to 12 year follow up, there was no decrease in differences in the cognitive, language, behavior, or other motor abilities. This sounds very reassuring. The other disproportionate intrauterine growth interventional trial at term, when these babies, when the babies who were small were discovered beyond 36 weeks with suspected growth restriction, they were randomized to undergo delivery or expectant management. And they were delivered only if it was indicated. These people also, they found there were no differences in these two groups. How do you screen? How do you diagnose fetal growth restriction? Of course, the cornerstone always will first be clinical measurement. Many times when we are seeing the patients in OP, we find it is not corresponding. Immediately we ask for a scan, although the patient has been coming regularly to us. And the basic thing is we take the fundal height, it corresponds to the gestation age. This has 85% sensitivity up to 32, 34 weeks. Ultrasound gives you various biometric measurements, and this directly gives you the fetal weight. And we all know fetal weight may deviate from the birth weight by up to 20%, but I think 20% is not acceptable now. It's up to 10% only, and it's as much as 95% of the cases. Sometimes if you plot these baby birth weights in a curve, sometimes they will underestimate preterm small gestational age. Now, what happens to this growth restricted fetus? It is one that fails to achieve its growth potential. The AC, like sometimes people take definition as less than third or fifth percentile, but generally what we do is we take it at less than 10 percentile of the standard growth. Now, these babies there's no increase in the AC abdominal circumference and or head or circumference, 2 scans 2 weeks apart. How do you evaluate these babies? First thing, you should assign fetal age. I'll come in the next slide. Assess the fetal size, estimate the baby weight, exclude anomalies. It's very, very important. Amniotic fluid is very important because, as I already mentioned, when there's a baby which is compromised, there is compromise to the renal flow. So therefore, the output of the baby decreases. Therefore, there will be oligomnios. Color Doppler and biophysical profile are very important in managing these babies. First guideline, when we have a baby, when we have a pregnancy, anytime you have a pregnancy, first thing you do is assign the fetal age, assign the EDD. Now, what we assign, this will not change. Now, the dating scan has to be done between 6 to 13 weeks and do serial scans. It's very important that serial scans are done. Exclude anomalies, infection, assess the placental structure if possible, and also see if there's any teratogen or any maternal disease. Now, in first trimester, what's the fetal biometry? It's very, very important that we compare the ultrasound gestational age with the LMP gestational age. In the first trimester, that's up to 12 weeks. If the dating EDD and the scanning EDD, if there's a difference between less than 1 week, then we go ahead with the LMP EDD. We assign that EDD as the correct EDD. Okay, but if it's more than 1 week, we have to reassign the EDD and make suitable corrections. Now, this is the first trimester. What do we do in the second trimester? When we do 14 to 20 weeks, when we compare the LMP EDD, the dates because of the dates and the ultrasound, if there's a difference of 7 to 10 days, then we go with the dating. The dating is considered correct. But if it's more than 10 days, we make appropriate corrections. What about 21 to 26? Even this, we can give importance to the ultrasound. But if it's less than 14 days, you go ahead with the same the LMP EDD as the dates. But more than 14 days, we make a suitable correction. But beyond 26 weeks, we must preferably avoid dating a pregnancy. Generally, we don't come across these kind of cases nowadays, okay? Even I work, as I told you, in the government sector. Very rarely we find a patient coming for the first time in the second or third trimester. Every patient, because of the very good antenatal care, all these patients are usually picked up in the first trimester, and appropriate scanning and care is given to our patients. You should not date beyond 26 weeks. It's preferably avoided. The patient prefers late, and usually they come with saying no reports. But there'll be some parameters can still be used, but be aware of the inaccuracies of the prediction of the EDD, and there's a high variability. Now, what's the second guideline? After you fix gestational age, after you assign the EDD, do not change dates in subsequent scans, and do not use machine generated data blindly. All our patients are very, very smart. They're very educated. Even they come to you saying, Madam, my ED is showing like this. Always emphasize that only the first trimester EDD and suitable corrections to the second trimester can only be the correct EDD. Now, if you usually what we do is whenever we have any patient, we always plot the growth curves. So the visual picture gives us a very good indication of how the baby is growing, how the baby is doing. And usually these will be usually parallel to the lines on the curve. And these are plotted every 2 to 3 weeks. If the baby is growth restricted, they will not be parallel to the normal curve. Now, this is appropriate for gestation age baby, that is a baby who is growing well. On the left side, we have a small for gestation age with low potential, and this baby is called the IUGR. They also, as I told you, there's a large for gestation age with high growth potential and macrosomia. In these big babies, always reassign, go back, check the dates. What we normally do is we always do the blood test again, especially the glucose tolerance, recheck for any impaired glucose tolerance. Because macrosomia babies also have to be monitored very carefully. And even when there is macrosomia, that means there is a problem, and we may have to take appropriate measures to deliver the baby. Now, the one thing that has revolutionized the treatment of these IUGR babies is the fetal Doppler. What does it tell you? It tells you the cause, whether placental or non-placental. It identifies hypoxia and fetal adaptation. It also helps us to plan the timing of delivery and to identify fetuses at risk of potential perinatal complications. Now, which are the vessels we do? Which are the vessels we do Doppler? That is, it studies the Doppler flow, the flow of the blood in these vital vessels. From the maternal side, you have the uterine artery, and from the placental side, you have this vital umbilical artery, which has been extensively studied, and various recommendations are based on that. From the fetal, there are also arterial and venous vessels, but mainly what we focus on is the umbilical artery. Okay, this Doppler was the umbilical artery was first used in 1977. And usually the umbilical artery, I'll show you pictures in the next slides. It has a waveform or a sawtooth appearance. And always the flow will be in a forward direction. Blood flowing through the umbilical arteries originates from the fetus, pumped from the baby's heart, and enters the placenta. The flow of the blood through these arteries is dependent upon the fetal heart strength and the health of the placenta. And the blood returning from the placenta goes to the umbilical vein to the fetus. Now, this umbilical artery, what I'm only focusing on today is it is evaluated by measuring the blood flow velocity at peak systole, that's maximum contraction of the baby's heart, and peak diastole, that's the maximum relaxation. And these values are then computed to derive a ratio. Okay. Now, as gestational age increases, the blood flow at the diastole means there's increased blood flow at the diastole, which means the placenta is less resistant. Now, we're looking at the umbilical artery. Now, this is the umbilical artery at 20 weeks. Okay. Now, systole, you can see the blood flow increasing, and at diastolic, this is the diastole. So this is systolic peak. This is the diastole. And here, there is a blood flow that is decreasing. Now, what happens? Because towards term, there will be a relaxation here. There will be a decrease in resistance. So even in diastole, blood flows through the umbilical arteries, which is advantageous to the fetus. Okay. Now, I'll only focus on the umbilical artery on the top. The below is the middle cerebral artery, which is also being studied, But all recommendations are based mainly on the umbilical artery. Now, this is, I told you, the sawtooth appearance is seen beautifully here. This is the control. Okay, this is systole, this is the diastole. So blood is flowing in the umbilical arteries, both to systole and diastole. Now, now if you see, this is the flow in the diastole is decreasing. Okay, is decreasing. And here, because of resistance is increasing. And here, it is decreasing in the diastole. And if you look at this picture, there is absent or zero. There's there is no flow. If you see, this is a systolic flow. In diastole, there is no flow. And in the next thing, what is happening is it is getting reversed. That means the resistance is so high and the baby is getting compromised. And here it is showing a reversed in the blood flow. So at this stage, when there is absent end diastolic flow here, okay, in this time, the baby can survive up to 1 week. But here, the baby can survive only up to 12 to 20, 24 to 48 hours. This is the time we start getting alert and take appropriate measurements to monitor and deliver the baby. How do you do the management? Every patient will do serial ultrasound every 2 to 4 weeks as indicated. And umbilical artery Doppler need not be done every week, at least 2 weeks. Once in 2 weeks, usually we do them in all compromised babies. And delivery depends on the underlying etiology and estimated gestational age. Now, when you're monitoring the fetus, it's always a dilemma. When do we admit the patient? The patients come to you with some scans. It is showing end diastolic flow, not there. What do we do? Usually, what we do in our hospital is we admit the patient because we are in a public sector. We have such a lot of patients in the OP. We can't sort out every patient. Then what we do is we should admit the patient and repeat the Dopplers. Many times, what Dopplers are repeated outside, they come back as normal. Okay, so we have to be careful is how we're interpreting these Dopplers, and if possible, do your own Doppler. Now, biometry, as I told you, is done every 2 weeks apart. If it's done every 2 weeks, then it's showing normal. But in compromised babies, this monitoring should be closer. We do it even sometimes twice weekly. We combine them with the CTG also. Severe oligohydramnios, as we know, indicates delivery. And one thing you must remember is acute hypoxia or acidemia may happen with normal LICA. So we cannot take any parameter and say, yes, this is the only one which is going to direct me to deliver. We have to always think of the baby as a whole and look at all parameters before we make a decision. The mode of delivery depends upon the parity, the cervical score, and the degree of growth restriction. In a well-compensated baby, the baby is good, but baby is small. With all reassuring fetal well-being tests and the diastolic flow, we usually offer vaginal delivery. But if the baby is hypoxemic, avoid trial of labor because the risk of decompensation in labor is very high as the reserve is poor. Now, if the baby is only having isolated fetal growth restriction, you can deliver at 38 to 39 plus 6 weeks. But if there's any problem, additional risk factors, deliver before. This is recommended by many organizations. Now, sometimes we have to deliver a baby before 34 weeks. Each baby has to be taken on a case-by-case basis. We cannot put a blanket rule for all babies. If the baby has to be delivered before 34 weeks, check your neonatal facilities. Is it able to handle this baby? Give antenatal corticosteroids. And if the baby has to be delivered before 32 weeks, magnesium sulfate should be considered for fetal and neonatal neuroprotection. Aim is the baby live or not? Can the baby survive outside? And you have to weigh the risk of intrauterine compromise against potential risk from the iatrogenic premature delivery. When to deliver? I told you, be careful. Each one should be think. Below 32 weeks, every day gained is useful. And every week, outcome improves by 40%. 32 to 34 weeks, give steroids and deliver. Best time to deliver is when the fetal redistribution mechanism starts failing. This is a nutshell, 24 to 28 weeks, individualize the patient. Any abnormal Doppler, take a call with the family. 28 to 32 weeks, monitor. Any abnormal Doppler, give steroids and deliver. 32 to 34 weeks, maybe it's a little bit easier to make the decision to deliver the baby. This is our grade restricted neonate. This is a big baby and this is a small baby. And This is the IUGR baby. The heads are disproportionately large for their trunks and extremities, and the face looks like a wizened old man. The neonatal complications are many: aspiration, hypoglycemia, hypocalcemia, etc. The long-term sequelae, yes, we are all worried about it. Up to 50% have cognitive disability, increased risk of cerebral palsy. Less than 50 will have a chronic growth lag, and less than 10% at the current ages. There's something called fetal programming, which has come now. That is, these babies seem to have an increased risk of metabolic syndrome, the hypercholesterolemia, diabetes, heart disease, that maybe IUGR has long-term effects which we are aware of. The take-home message, what I'd like to say is, fetal growth restriction is a problem. Risk factors should be assessed. Each case should be assessed individually. There should be proper antenatal care and advice should be given. Diet and supplements. Supplements have now no role. Before they used to give oxygen therapy and IV fluids, giving rest. All this has no role in treatment of IUGR babies. But the only thing that may have some small role is they're saying protein supplements, but it's not yet proved to some level. Ultrasound and growth chart should be interpreted monetarily, and color Doppler and intervene timely. This is my last slide, which is very good. It was said by an unknown medical student in Dublin in the UK in 1982. I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out. It's very significant and appropriate, especially for your IUGR babies. Thank you.
Thank you so much, ma'am. Thank you for your wonderful talk and for such a lovely presentation that you have shared on our platform and for making our viewers understand about this topic in such a beautiful manner. Thank you so much for that. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you.
Yeah, sure.
So the first question is related to the long-term implications. So what are the long-term implications of IUGR for both the fetus and the neonate, and how should postnatal follow-up be structured?
See, what I like to say is the long-term sequelae, nowadays we are able to follow up babies long-term. And there seems to be a sequelae. There seems to be a slight growth lag. There seems to be some kind of cognitive problem. But they do well on the whole. But on the other whole, I just told you some Barker hypothesis has come up, that is, these babies are having more chance of having metabolic syndrome, more chance of having strokes, dyslipidemias, and hyper. So whatever it is, any insult in the womb is definitely going to affect you in your long-term life. Okay, more studies have to be done, but what available thing is there does seem to be some problem.
Thank you so much, ma'am. Thank you for answering that question. We will move to the next question that we have received. And the next question is related to the ultrasound and Doppler that was also there in your slide. So how can ultrasound and Doppler assessment aid in the diagnosis and management of IUGR? And what are the key parameters to consider?
Yeah. See, what we do ultrasound is what basically we do is the biophysical profile and the Doppler. Now, what in our hospital we do routinely is at 34 weeks, we do a growth scan. Okay. And that growth scan, because we cannot be doing the biophysical profile for all patients. No, it's not possible. So we do at 34 weeks, we are doing a growth scan. If it is corresponding, clinical examination, we do at every step. If it is corresponding and there's no high risk factors, this patient is monitored and the patient comes back in the last time, after 36 weeks with the biophysical profile and Doppler. Now, all of us have realized that biophysical profile and Doppler are very good, especially, and now there's a modified score in which they take only 4 parameters and also a simplified score. So those scores will tell you, is the baby going to be good in the next 1 week or so? A normal baby, if you do a biophysical profile and biophysical profile, 1 week it holds on. But if the patient is having hypertension, the patient is having diabetes, IUGR, these parameters should be repeated more frequently. Now, as I told you, the fetal Doppler is very good, especially the umbilical Doppler. We as gynecologists also can do it because we can easily diagnose. So we are able to do it. But what we are not doing it routinely. We just do the parameters, we do the biophysical profile, but the Dopplers are being done by the radiologist. Now, in these things, if there is a compromise in the fetal Doppler, immediately we have to take a call. And as I told you, a single parameter will not make us terminate the baby. Supposing a patient is having hypertension and you find a compromise in the either biophysical profile or Doppler, you take an earlier decision to deliver the baby. Okay. And our neonatal care is excellent. We have a very good pediatrician who's able to tackle very good babies. Even 28-week babies are able to do well in a government institute. So you can imagine the private sector, how much better it is. So, as I told you, each case is individualized, each baby is individualized, and depending on neonatal care, you can take a quicker thing. Supposing a patient is having this baby after 15 years, okay, or this IVF baby, then maybe taking out the baby in a hostile environment may be a better decision than continuing it. Even if we continue, we probably give steroids or whatever, take the help, and we have a multidisciplinary team, and then we take a call about delivering it. As the last slide I told you, the one about the womb being the tomb, we should not allow the babies, we cannot lose babies nowadays just because of whatever reason. Okay, I hope this answers your question.
Thank you so much, ma'am. Thank you for answering that question with such an elaborative answer and for making our viewer understand about the question so well. Moving to the next question that we have received, and the next question is related to the indications. So, what are the indications for early delivery in cases of severe IUGR, and what strategies can be employed to optimize neonatal outcomes?
Outcome, yeah. See, as I told you, uh, each case has to be individualized. And before, if you look up, there are a lot of things, IV fluids, L-arginine, oxygen therapy, all those things, no, none of them have found any value. Okay. So basically, you cannot treat IUGR. You cannot really, even bed rest. For a long time, they were saying bed rest will help, let the patient be on the side, but that has no significance at all. What can really help is monitor the other parameters, which supposing it needs a control. And if the IUGR is very severe, maybe it's a better decision to deliver the baby than keep the baby inside. For some reason, there's a placental reason, or it's the baby itself has a chromosomal problem. Maybe the baby will do better outside. So it's a combined decision between us and the neonatologist and how we deliver the baby.
Thank you so much, ma'am. Thank
Also,
you for
remember I told
yeah.
you the baby can also be a large baby, that may be most probably diabetes. So even if the blood sugars are normal, okay, if the blood sugars are normal, why has the baby become so big? Did we miss something earlier? So even in these babies, we take a call. There is a problem, and so deliver baby. We are better off delivering the babies outside.
Thank you so much, ma'am. Thank you for answering that question. And moving to the next question that we have received, the next question is related to the current guidelines. So, what are the current guidelines for the management of pregnancies complicated by IUGR, including monitoring and interventions?
Yeah, I think I covered it. See, as you say, there are such a lot of causes leading to IUGR. Okay, the early IUGR, nothing much can be done, isn't it? The early IUGR, the early symmetric IUGR, nothing can be done. But luckily for us, most of our IUGRs will come later. So we sort of push them on to period of viability. And if any compromise, the patient the baby is compromising, is getting a problem, then those babies we have to terminate. Okay, there's no current guidelines because each baby, the reason is different. I think many times I have noticed we don't know why certain babies are not growing. Okay, everything will be normal. Everything will be normal. There will be placenta will be normal. Even as you look at the baby, there'll be no problem in the blood sugars or in the BP. Nothing will be wrong. But still, the babies are not growing. We really cannot understand why. And also, we have also seen many times. Second time also, baby will be having oligohydramnios. Oligohydramnios means either there's a problem in the placenta or in the renal problem, but babies come out healthy, they do well also. So there's also the other part to it. God looks after these babies in spite of us intervening, isn't it? As of such, there's no current guidelines, for each baby. Each baby has to be individualized and treated.
Thank you so much, ma'am. Thank you for answering that question. Moving to the next question and the last question before we conclude. So, the last question is, how can prenatal screening and diagnosis of IUGR be optimized, particularly in high risk pregnancies?
pregnancy. See, now I think all babies, all pregnancies are high risk. Okay, we are very careful. We have the gestation score, and even as I told you, I deal with large number of babies. Okay, large number of pregnancies because I'm in the government sector. We have about 1,200 to 1,400 deliveries a month in our hospital. So we cannot afford to miss. So we have certain guidelines. What we do is every patient is screened. It is clinically seen by us. All tests are done routinely in the prenatal, and most of the our government has given us most of the tests to be done. Okay, so the patient will not go off saying that because I can't afford the test. Nearly all 99% of the tests are being done in our hospital free of charge, and so the most of the time, and even if anything is missed, we have the ASHA workers also who cover them. Okay, and we have a very good referral system in our hospital, in our state. So any patient will not be neglected as such unless for some other reason. So proper prenatal guidelines. In case a patient had a baby who's IUGR, even we give them prenatal screening. Okay, then we allow them to get pregnant. We follow them up. So basically, I think healthcare has improved to a great extent, not only in our state, all over the country. So that is why we are having better outcomes. There's no doubt about that.
Thank you so much, ma'am. Thank you for answering all the questions for our viewers and making them understand about it. Thank you so much for solving their queries out. And I would also like to thank all of our viewers for putting across their questions to us and for their ardent participation. And on the outset, I would like to thank you, ma'am, for taking out your valuable time and for being here and doing complete justice to the topic given, because the way you have explained the topic, I think no other would have been a better person to make us understand about the topic in such a better manner. Thank you so much, ma'am.
Wow. Thank you so much,
So,
Patel. It's a
with all
pleasure.
your last comment, ma'am, we can conclude the session here for today.